Thank you all. Thank you, Dr. Subhashini, Dr. Kavita, and others. So I'm going to now speak on what happens when you are at the end. The trap is failed. So what do you do next? So we have to explore alternative treatment options here. So what is failure? Trabeclectomy failure is defined as inadequate IOP control, persistent hypotony, requiring further glaucoma surgery, and loss of light perception vision. The IOP criteria failure is defined as persistent hypotony, that is IOP less than or equal to 5 mmHg, IOP more than 21 mmHg, and IOP not reduced by 20% below baseline. So TRAB can fail for many reasons, and understanding failure mechanisms helps in selecting treatments. So how common is TRAB failure? It ranges from 10 to 50%, varying with risk factors, and the high risk in this category are a young age, repeat surgery, inflammatory glaucomas, and long-term success depends on follow-up care. So what are the consequences of a failed TRAB? You have persistently high IOPs leading to glaucoma progression. You have worsening visual fields and dependency on medications, which reduce the quality of life, and there is a potential need for additional surgery. So why does a TRAB fail? Early failure may be attributed to hypotony, blood clots, leaks, and infections. Late failure may be due to exaggerated healing response, that is fibrosis and scarring that block the drainage. And of course, the immune response plays a role in excessive healing, particularly in inflammatory glaucomas and in young patients. How do you recognize TRAB failure? You have increased IOP, poor drainage, that is a flat or an encapsulated bleb, which you can see on your right side. It's a totally vascularized flat bleb. And of course, the patients may be symptomatic. If the pressures are really high, they may have blurred vision, discomfort, pain, and redness. What are the non-surgical treatment options? You have AGMs. You can try all of the AGMs depending on the situation, but maybe we can cut back on the PG analogs if there is ongoing inflammation. Laser therapy, SLT, particularly in open angle glaucoma cases, may be tried, and a combination of both AGMs and laser therapy can be tried. That would be called a qualified success if it works. But more importantly, ensuring compliance and regular monitoring visits are very important, as failure tends to be progressive. Surgical treatment. So we have rescue surgery, that is bleb needling, or a TRAB revision. Again, both the bleb needling procedures have a limited success beyond 3 months post-operative. So better to go in for a bleb needling as soon as possible. They will require an antifibrotic injection, as Dr. Kavita just showed. Or one can reopen the TRAB site and remove the episcleral fibrotic tissue and do it. But again, beyond 6 months, these things don't work. So the alternate surgeries here are a repeat TRAB, a GDD, a MIGS, cyclodestructive procedures, particularly in patients with poor visual potential, and subcyclo procedures, but they tend to be less efficacious because that would just act like one AGM. So choosing the right surgery. The severity of glaucoma determines the approach. So aggressive management is warranted in severe disease, and caution in younger patients and those with inflammatory conditions. The type of glaucoma. If it's an open angle glaucoma, one may try angle-based procedures if not done earlier. Secondary glaucomas tend to be severe and refractory, so GDDs may be better. Previous surgical history limits options oftentimes. So for example, there's extensive conjunctival scarring, and previous surgeries have gone all around the conjunctiva, then the only options left would be a GDD or a cyclodestructive procedure. And patient-specific factors like age, adherence, risk tolerance. Now, these are things we have to discuss with the patient before we counsel them for the next step. When to attempt another TRAB? TRAB is the most common choice of second surgery. So it must be considered if we have viable conjunctiva that is untouched by any previous surgery. And if there are alternative surgical locations at the limbus. There is a lower success rate than the initial surgery, and use of antimetabolites, that is mitomycin C injections, and releasable sutures will definitely enhance the success. Close post-op monitoring here is very essential. You may have to see them on a weekly basis. And in certain situations, it may be the only options. For example, infants at a very young age, you may not have the choices. You may not have too many choices there. Glaucoma drainage devices, again, is the most common choice in recalcitrants and refractory cases. So you have in patients with extensive scarring, fibrosis, where you cannot do a TRAB, like in this case. For example, already have more than 2 failed trabeculectomies, you have secondary inflammatory glaucoma, then just go in and put in a tube. So the AGV is a flow restricting device. It reduces early hypotony, but the RDR Barwell, which has a larger plate, gives better long-term IOP control. Minimally invasive glaucoma surgeries, again, it may be effective in mild to moderate glaucoma. There aren't too many people who do it. So the iStent and Hydrus, there are some case reports. It may enhance trabecular flow, but GAT has been reported to be successful in at least 3 studies in the short term. That is at 1 to 2 years. These studies have shown to be, the GAT has been shown to be successful even following the trab. Cyclodisectory procedures are for refractory glaucoma cases, particularly in patients with poor visual prognosis. Cyclophotocoagulation, the CPC laser, reduces the aqueous production. Cyclocryotherapy is freezing, but again, this tends to have more complications, so better to do cyclocryo only for very poor visual prognosis cases. And subcyclo lasers may be considered in patients with good visual prognosis, and the effectiveness is that of just 1 AGM. And this is again a failed trial in an infant where we are doing a subcyclo procedure. So how do you ensure successful outcomes? Frequent IOP monitoring, so much closer post-op visits in second procedures. Managing post-operative inflammation, so greater frequency and duration of steroids. So you need to give the steroids much more frequently than you would ordinarily after a primary trab, and you must continue it longer. Most people will continue it for at least 3 months to 4 months. And oral steroids may also be needed in post-peak keratoplasty or post-uveitis patients. Early rescue in case of failure is important to recognize early failure. Hence, the weekly visits may be warranted here. Suture lysis, antimetabolites, blebrusion, the whole package, everything may be tried in these patients. And patient compliance here hence becomes very important. So it's very important to explain to the patient that strict adherence to medication and a follow-up routine is extremely essential. So routine eye exams every 3 to 6 months, monitoring visual field progressions and adapting treatments as needed. Future directions, new drugs targeting fibrosis are on the anvil. There is gene therapy and stem cell therapy, again at very nascent stages. And these are just 2 case studies. One is the successful management with the repeat trab. So in this case, we had done a third trabeculectomy over a period of 10 years, and it still worked. So you may not give up. So many senior people who do trab for many years, they also would say, yes, you can do. And then the second case is that of a GDD placement in a high-risk patient. Here again, there's so much fibrosis. There is absolutely no occasion here to do a second trab, so it's better to go for a GDD. So the lesson here is the importance of individual care. So key takeaways, trab failure is not the end. Various surgical and non-surgical options exist, and personalized approaches ensure better outcomes. Thank you for your attention.
Thanks, Dr. Geeta, for finishing well ahead of time. So we have come to the end of the session, and we can take up questions, if any, from the floor. So we have time of another 7 minutes. Any questions from the audience? Yeah, come over the mic. And just turn it. I think it's on.
Hello. Ma'am, at which site we should prefer doing the trabeculectomy?
The retrab.
Yes.
So it is always recommended when you do the trab initially to avoid touching the 12 o'clock position. So you can either do the first trab nasally or temporally, so you have more conjunctiva left. So if you have done a trab nasally, say in the first instance, you can go temporally. Or if you have done a slightly temporal trab, you can go nasally. But it is preferable to stick to the superior conjunctiva. If you have no superior conjunctiva, very, very, very extreme situations, I have seen only experts do that. They do an inferior trab, but they will do it either inferonasally, and that may work for some time, but as I said, that's a very extreme situation, and it has to be preferably done by an expert.
Yes, now there are better options. So better to avoid an inferior trab because of the high chances for infection.
But once the trab is failed, so secondary surgery we have to prefer trab only, or we can?
No, as I said, see, if you whatever can be done for the patient. Like you saw the 2 case studies I showed you. In one case, we have done a third trab as well because there was conjunctiva. Fortunately, we had conjunctiva there. We did the third surgery and that worked, and the patient is doing well. But in the another case I showed, there's absolutely no conjunctiva. So there is no option of doing even one trab. Sometimes you just have to go straight away with GDD in some cases. So
that third trab you did in the superior
conjunctiva. If you see I'm sorry I can't show you the picture again, but you see there are 3 PIs there. It was done. But again, that's That's just that it was a late failure and there was untouched conjunctiva there, so the trap worked. But that is not recommended. You might go for a GDD the third time instead of a third trap. Only in very extreme one-eyed patients, you don't want to take a chance. Yeah.
There are more chances of failure with the second or the third trap. So you see for the conjunctival mobility how it is, and then decide which site you would want to do the second trap.
Thank you.
Thank you. Yeah, please come.
Ma'am, if post-trap we get an encysted bleb, so how early we should intervene and go for needling?
As soon as possible, particularly if the IOP is high.
Yeah.
We should not wait for
Like,
conservative.
you can try. There are articles which describe no aqueous suppression in these eyes, especially when the blood is getting localized. It means like the aqueous is getting collected over there, and you can just put them on aqueous suppressants and observe for a couple of weeks. But if the intraocular pressure is getting elevated, these encysted blebs, like unlike the vascular flat blebs, you can even try a needling in the OPD itself. But you make sure like suddenly you will get a flat chamber. You should have your assistant, the pad and bandage, everything ready like before you start the procedure. Make sure you explain the patient, make sure you have the caregiver by the side, and discuss. No, here also you have to take a consent. So you can try the initial aqueous suppression, and if it is not helping, you can go for a bleb needling.
Yeah, typically the encysted bleb occurs a month after. Nice, the pressures are well controlled. You feel so happy. Then slowly the bleb
4 to
encysts.
6
Yeah,
weeks,
but yes, 4 to 6 weeks. The bleb gets encysted. So for this, actually needling is one of the best techniques for encysted blebs. It works well. So no needling otherwise will not work in other cases, but encysted bleb it works well. So conservatively, if you want to try, you can just use the aqueous suppressants for that period of time. And then once the bleb, you can visualize if it's somewhat becoming, the height is reducing, then and the pressures are better, then you can just stop the anti-glaucoma medication.